That way, this will be viewable, but the only way you're going to get phone credit is by live virtual viewing. So what we'll do, we'll keep a record of after the hour-long seminar with Raj, or with Rajan, to see who's here for the entire length of it, and then we'll keep that in our records. At the end of the year, we give a completion certificate that's good for fellowship credits. So welcome to the College of Remote and Offshore Medicine. We are based in Malta, even though I'm not in Malta at the moment. I am in the Black Forest, and there's and our 23 faculty are all over the place. Vish is coming in from Louisiana, so he'll be speaking tonight, and and Tim just joined as well. He's on faculty with us. Rod Jordan's on faculty with us. I'm not sure where Rod is. Probably Kurdistan. But so we have a bunch of faculty from around the world who come together, and we do the best we can. So this is something I've been wanting to do for a very long time, and thankfully Gabby from the WMS has authorized us as the only non-medical school to be approved to run these SIG programs, and we'll run these. They are focusing on remote austere wilderness medicine, and there'll be varying topics on the first Tuesday of every month. So before I hand over to Vish, I just want to ask all of you guys, make sure you keep your microphones on silent. I'll do the same. If you have any questions, please put them into the message. Myself, Vish, Tom, or Rod will answer them. And at the end, Vish will have some time for Q&A on his topic of dive medicine, as well as any questions about the WMS program, the student interest group, the fellowship, everything that you might want to know. So welcome to the first SIG seminar. I'm honored you guys are here, and I will pass you over to Vish.
Hello everyone, and welcome to our WMS Student Interest Group seminar series. And this is the first. I'm just going to start sharing my screen. And can everybody tell a break on the chat, but it's visible?
Yeah, looks good. Looks good.
Okay. So like I said, welcome to the Wilderness Medical Society Student Interest Group lecture series from the College of Remote and Offshore Medicine. I am Vish, and I will be presenting on diving physics and physiology today. So diving physics and physiology cannot be complete without a goat in a hyperbaric chamber. That's something which I always like to share with people, that this is most of our tables, most of our research has been on goats and other animals and military personnel. So you got to be careful about what you're dealing with. A quick introduction on myself. I'm a technical public safety and research diving instructor. I'm also a full cave and closed circuit rebreather diver. I'm a paramedic and a diving medical emergency responder instructor, and I'm faculty on Corom and at KMC Manipal. I also have a dive shop in India, and I've been diving since 1999, so I have a fair bit of dive experience. Today we're going to talk about history of hyperbarics, basic dive physics, some physiology and barotraumas, the decompression, which includes a little bit of decompression theory. Dive computers is going to be a bare overview, and then we're going to follow into question and answers. I'm going to try and keep it about 30 minutes to 45 minutes, since we have a fair amount of time for question and answers if required. So history. Well, hyperbarics has been around for a while. Robert Boyle was the first person who actually built the contraption you see on the right, which is a vacuum flask, and he experimented on animals, and his first experiment on a viper was where he first noticed discomfort from decompression in a viper's eye. And what he says is that the poor creature was writhing in pain, and he noticed a bubble in the aqueous humor of the eye. Paul Burt, and some of you who might be more familiar with aviation medicine would be familiar with his name. He was doing high altitude balloon studies, and he's also one of the pioneers for hyperbaric medicine as well. He is the one whose name comes up with oxygen toxicity as the Paul Burt or the Burt effect. John Scott Haldane was the first physician who was commissioned by the British Navy in 1908 to create the first tables, and he did a lot of experiments on himself, his family members, in chambers to come up with those tables. Robert Workman is one of the US pioneers of decompression theory. A lot of you all might have heard of Albert Buhlmann and the Buhlmann tables. He pioneered decompression studies and has 3 books. One book called Tosh Medicine, written in German, and the last edition, 1995, hasn't been translated into English yet. Merrill Spencer was a relatively newer decompression theory researcher, and he did research a lot on the bubble models and on Doppler. Ed Thalmann comes up in again working in the NIDU, and he was the head of the NIDU for a long time. He's the one who came up with a slightly different method of decompression, where he did not think about it purely as linear or exponential, but came up with a mix between a linear and exponential model. We'll talk about those as we go ahead. So this is Dr. John Scott Haldane in his chamber, and just like the goat, he experimented on himself and his family. It's important to understand history and realize that it's been a long while since we've been talking about diving medicine, yet we don't see much of it spoken about in traditional medicine. This is Albert Buhlmann and Hans Keeler during their deep dive to 300 meters when they formulated deep trimix tables. So this is one of the bubble model and Doppler screenshots of, if you see the one on top is a normal pre-ascent image, and the one below is a post-descent image where the sheep was decompressed rapidly, and you can see the bubbles that have formed in the IVC. And this was in 1968, and Dr. Merrill Spencer was the one who conducted these experiments. So now to come to diving, we have 4 basic types. One is breath hold, where you hold your breath and descend. Kind of a lot of people do that snorkeling in pools, and then you have scuba diving, which is basically self-contained underwater breathing apparatus, which is, and you see the images are clockwise from left to right. So the scuba diver has self-contained equipment. He carries a tank of gas, regulators, and associated equipment, which gives them safety underwater. The surface supplied unit is one mostly used by commercial divers and working divers, including the military. Some public safety teams also use surface supplied units. Here the gas is supplied from a surface unit. They have compressed gas stored in cylinders or a low pressure compressor, more or less cylinders nowadays. Low pressure compressors was earlier. And then you have the 1 atmosphere suit, in which the diver is basically at 1 atmosphere inside. It's pretty cumbersome outside of the water, and even inside the water, you just have very limited dexterity of using tools, but it does not require decompression. I don't have any experience in the 1 atmosphere suit. I've done all 3 of them. Now we come to physics, and the key things that as divers we need to know is pressure, volume, density, and temperature. These are the things that affect dive physics a lot, and the most important parts of our of the physics lecture today. So just to give you an example, people talk about 1 atmosphere, which has different meanings to different people, And so to give you a breakdown, it's about approximately 10 meters of seawater, 33 feet of seawater, or 34 feet of fresh water. And when you are using PSI, which is most common in the US, it's about 14.7 or 15 PSI. So when you talk about diving, people talk about bars in their tank. So how much gas do you have? I have 200 bar. So 200 bar would be equivalent to 3000, approximately 3000 PSI, and so on and so forth. So for the most part, we use bars and PSI interchangeably in terms of 1:15. Now, the gas laws that you need to know are Boyle's law, Dalton's law, Henry's law, and the general gas law. The general gas law is a combination of Boyle's law, which also relates to temperature. So to go ahead, Boyle's law is basically a pressure-volume relationship. And it says that if the pressure in a closed system, if you change the pressure, the volume inversely changes. So similarly, if you increase the volume, your pressure is going to drop. So this is an example for us as divers and how Boyle's law affects us. So at 1 bar or 1 atmosphere pressure, the volume pressure ratio is the same. As you descend, as the pressure increases, the volume halves. And similarly, as you ascend from for 30 meters or 4 atmospheres, as you ascend, the pressure volume keeps changing and keeps increasing. Now, the effect on our lungs is similar when you're doing breath hold diving. However, when you shift to using open circuit scuba or closed circuit scuba, what happens is the gas that you breathe is at ambient pressure, which means that the pressure on inside your lungs is the same as the pressure outside on your body. So that's one of the reasons why you have on-gassing, because you're breathing gas at the pressure which is external. So about, let's say you're at 20 meters, you're breathing gas at 3 atmospheres. So there's going to be a pressure gradient between your blood and the gas that you're breathing, and therefore it will cause diffusion or absorption of the gas inside. And why I'm telling you this is, as we go forward, you'll understand partial pressures and gas absorption. So when we talk about pressure, the key thing that we're talking about medically is barotrauma of pathophysiologies, and we want to know what happens and how these things are formed. So the basic concept being you have a mask squeeze, which is formed by not having adequate equalization in your mask. I'm just going to go ahead and show you images here. So the diver in this case, if you notice here, the mask has a pocket. Now that nose pocket allows you to exhale into your mask space, which is the window, and equalize the pressure in that area. Now, if you forget to do that, or you don't do it fast enough, it's going to be a negative pressure created, and that causes severe capillary damage. And it's not very significant. It resolves on its own within 24 to 48 hours. So now we come to basic sinus anatomy here, and these are again air spaces in the human skull. So we realize that pressure transmits. Think about your vehicle, right? If you have hydraulic steering, the pressure gets transmitted across, so there's no change in volume or change from pressure. When you press on the press on the brake lever, the pressure gets transmitted. That's what happens with your blood and your solid organs and solid parts of your body, your muscles and bone. Whereas with the sinuses, which are gas spaces, you have changes in pressure which can cause minor capillary bleeding or rupture of certain minor vessels. And similarly, when it comes to your ear, you have air spaces and open spaces in the eustachian tube and the inner ear, as well as the auditory canal, which generally does not fill with water. There is a small gap which is created. And again, why I show you this is to just get a kind of refresher on the spaces which where barotrauma can happen because of the pressure differential created in the gas. So middle ear barotrauma is what we're going to think about the most. It's the most common two barotraumas in diving is inner ear barotrauma, middle ear barotrauma, and sinus and mask squeeze. So this is a grade 0, which is a minor change. There's not much difference. There's not much pain. There will be a little bit of heaviness in the diver when they come back, and they're probably going to complain of mild heaviness and slight headache. But otherwise, there's no trauma to the tympanic membrane. This is a grade 1 where you can see the clear difference between the baseline. There's either fluid or air, which is clearly visible, and a simple otoscopic examination will show this up. A diver may or may not indicate pain depending upon how what their pain threshold is. So remember, in most cases of the grade 1 and grade 0 barotrauma, they may or may not indicate pain. This is grade 2, where there is a rupture or significant bleeding, and in any case of barotrauma that you suspect, you would immediately take the patient or the diver out and stop their diving for a week. Antibiotics typically may be required for tympanic membrane perforations and pain relief as required. Now, inner ear barotrauma is more significant, and as you've seen the anatomy of the ear, the change happens primarily when the pressure difference is inside the tympanic membrane, and it can cause sudden vertigo, a loss of balance, spatial orientation, and this is pretty significant in a diver if they're at depth, because they can make a mistake of it, and instead of going ascending slowly, they might ascend or descend, which can further the problem, and you'll have tinnitus, nystagmatism from the inner ear barotrauma. It needs intervention, and once you're back, once the diver has surfaced, it's important to have a full medical evaluation for this patient, especially by an ENT. Now, pulmonary barotrauma is what you would consider one of the worst cases, and it's a straight off emergency. You would activate EMS as soon as you have a suspected pulmonary barotrauma patient. It's hard to detect on a patient if you do not have basic medical facilities, or a stethoscope, and you just have to go by clinical symptoms. Now, the worst case in this situation is a cerebral arterial gas embolism, where the gas emboli transfers across from the venous side to the arterial side, and then causes embolism in the brain. And most often in this situation, it will present as a stroke. The other presentations of pneumomediastinum or subcutaneous emphysema are more benign, but again have to be treated as an emergency. Pneumothorax would be, again, the treatment for all of this is to put the patient on high flow oxygen and get them to definite care, which would be a hyperbaric chamber with stroke capabilities as well. So remember, anything that you suspect where a patient is not in the normal mental status, especially after a dive, consider that they have decompression sickness and assume that it's a pulmonary or cerebral in the nature. Immediate evacuation and urgent imaging and labs is primary. Most dive boats carry oxygen as a safety measure. It depends upon how much capacity they have. They're generally small units. Some boats have bigger oxygen units as well. So if you're on a boat, remember, just get the ABCs and put them on high flow oxygen as soon as possible. So we go back to dive physics again, And here is where we were talking about different gases and why you would have on-gassing and off-gassing. So as we know, air has about 21% oxygen and the remainder of 79% is inert gases. So the partial pressure of a gas makes a difference in the on-gassing and off-gassing, because in some cases in diving, you're not using just air as the diving gas mixture which you're breathing, but you're using mixtures. And those mixtures, as there's a pressure gradient, will diffuse greater or lesser as the case may be. We'll talk about different gas mixtures as we go ahead. But this is just a generalized image. It doesn't actually happen like this, as you all know. But if you think about you're diving a gas with three mixes, you have, a mixture with three different gases, you have the sum of the partial pressures of the total mixture is the sum of the pressures of each gas. Now, these are the most common gases that you use when diving. Air, enriched air nitrox is basically air with a mixture of oxygen. So you have a higher percentage of oxygen in the gas mixture. Pure oxygen is used on rebreathers and gets toxic beyond 6 meters or 20 feet. Heliox is a mixture of oxygen and helium, primarily used for dives deeper than 30 meters, 100 feet. Basically, to keep it, as the pressure increases, the breathing gas density also increases. And as it gets denser, it becomes more difficult and to breathe, or the work of breathing basically increases. So you want to have a lighter gas to be able to breathe comfortably, which is why you use heliox, which is helium and oxygen. Trimix is slightly cheaper, used more recreationally. Because it's cheaper, it's a mixture of air and helium, or helium, nitrogen, and oxygen. Again, used to reduce the density of gas as you go deeper. Experimental gases are used for dives which are, in fact, any dive beyond a particular depth starts becoming experimental, because you're mixing your own gases. You're trying to use, in some cases, a custom mix that will be best for your dive. And we've used hydrogen oxygen mixes, helium hydrogen oxygen mixes, some other inert gases have been used, but the heavier inert gases tend to get more narcotic and more anesthetic. And one of the other reasons why you use heliox and trimix is to reduce the narcotic effect of inert gas. Oxygen, nitrogen, and most inert gases are highly narcotic and cause symptoms of anesthesia at depth. So this is again a rough image of a table which I use for when I'm diving, and anything in the red is not safe to dive at that particular depth, primarily either because of the density or because of the percentage of oxygen that makes it hypoxic or hyperoxic, and that you do not want to endanger yourself. And you can see on the extreme left, you have the various mixtures and their notations. So the way you note enriched air nitrox is EAN32, which means it has 32% oxygen, and the balance is nitrogen. In EAN36, similarly 36% oxygen, and the balance nitrogen. In trimix 2135, you're noting the oxygen percentage first, so 21% oxygen, 35% helium, and the balance is nitrogen. Similarly, trimix 1265 is 12% oxygen, 65% helium. Now, you'll notice some of these gases are hypoxic, which is below breathable percentage of oxygen, which means that you have to carry an additional gas mixture, which is used for travel to a particular depth. So you start off the dive at using maybe enriched air gas and the gas mixture, and then as you move deeper to the working depth of the gas, you switch to the trimix or the hypoxic mix. So now we go, as we move across, we move to decompression. And so for decompression, you want to understand how gas gets dissolved. So for gas dissolving in a body is governed by Henry's law. And Henry's law basically states that the amount of gas dissolved in any liquid is directly proportional to the partial pressure of the gas in contact, which basically means that if you have X amount of gas on your body, it's going to be proportional, directly proportional to that amount. So for example, at 1 bar, if you have, let's say in this particular example, 6% of a particular gas, at 2 bar, it's going to be double, and the diffusion is also going to be double. The dissolution into the body is also going to be double. Now, bear in mind, when you're talking about gas going into human bodies, you're dealing with multiple gas laws, Boyle's law, Dalton's law, Henry's law, also Fick's laws of diffusion. And I'm not going too far into it because that will be a completely different chapter or seminar all by itself. But these are the basic concepts that we need to understand when it comes to dive physics. And so when you talk about breathing gases, and I showed you the graph and the table, you have pathophysiology is based on the gas that you're breathing as well. So you can have oxygen toxicity when you breathe oxygen at depth beyond 6 meters and even at high partial pressures for an extended period of time. Anytime you're breathing oxygen beyond 0.5 bar in partial pressure or 50% partial pressure, it starts to get toxic, and long-term exposure can cause pulmonary and retinal effects. Carbon monoxide poisoning, I guess most of us are familiar with. Hypercarbia, again, when you're diving, at times you have divers who are working too hard, which builds up carbon dioxide in their body and leads to them overbreathing, not ventilating properly, and can cause unconsciousness and further other effects. They can black out and drown. Hypoxia, again, we already know a lot about hypoxia. Narcosis is something which basically causes an anesthetic effect of breathing a gas. And those of you all who are anesthetists would have seen how, would have studied this. But the main thing when you're diving, gases that are lighter, which is hydrogen and helium, are less narcotic. Nitrogen, oxygen, and all the other gases that are used, inert gases are used, are narcotic, and the narcotic effect of those gases depends upon the lipid solubility. So the more soluble a gas is in a lipid, the more narcotic it is. So we now talk about respiratory physiology. And as you know, the lungs and alveoli are our primary gas exchange areas. So the mechanism of gas transport here in the human body, as is shown here, you have the gas being gas coming into the lungs, where it is taken in and then off-gassed at the tissues. So think about it this way: as you breathe in, you're on-gassing. It transmits, the gas gets transferred by the heart and the capillaries and the cardiovascular system. It then goes onto the tissues, it goes to the tissue bed, and it off-gasses in the tissues. The main thing to understand here is that as long as there is a pressure gradient and a partial pressure gradient, there is going to be on-gassing or off-gassing. So one of the main decompression models we talk about is dissolved gas, and the second one is dual phase. So in both these cases, you have gas getting dissolved and forming bubbles is what you do not want them to do. So as you descend, gas gets on gas, and as you ascend, you're going to be off gassing. So you do not want the off gassing to create bubbles. So the primary aim for a decompression model is to prevent pathological bubble formation. So in this situation, in this image, you can see the gas is being taken up in the alveoli through the capillaries and into the bloodstream. And the you have fast and slow tissues based upon perfusion. So the dissolved gas model bases the gas absorption and elimination based on perfusion, and therefore as human tissues are different in perfusion rates because of the way they are the way they are built, hypothetical tissue compartments were made to explain how different tissues are on-gassed or off-gassed. Now, one of the main assumptions in most dissolved gas models is that the uptake and elimination is constant, which is it's at the same rate and it is exponential. Now, if you have understood, if you remember anything from nuclear physics, it's called a half time. So similarly to tissue on gassing and off gassing, because it's exponential, it's called the tissue half time. And as you on gas, as pressure increases, you on gas, and as pressure drops, you off gas. Now, again, like I was talking earlier, this depends also upon the gas you're breathing, the time at depth, and your body perfusion systems, and how you're generally metabolizing the gas. This is a graph of approximately how it is based on the time as you go ahead. Now, just a quick demonstration of how the dissolved gas model. Imagine this is a tissue. At a first half time, you have 50%, and generally by the fifth half time, you're almost at 96%. So in 6 half times is when you would consider the gas to be, your tissue to be completely saturated with gas. So the table on the right is the table which Albert Bullman created, and it's a 16 compartment table for different tissues. And it's notice the fastest tissue has a half time of 4 minutes, which basically means that within half an hour you're already saturated that tissue. That is mostly your lung tissue and the capillaries directly in contact with the lungs. Now we move to dual phase models, which is basically just says that we know now from Doppler and other means of measurement and imaging that bubbles exist, and we have cavitation that creates bubbles when joints move. So we want to try and keep the size of the bubbles subpathological as long as the diver is ascending, and once the diver ascends, we hope that the bubbles haven't increased in size to cause any injury to the diver. So basically, you're just trying to keep the size within that limit and not go beyond a particular limit. Now, as you know, every system seems to equilibrate with its surroundings. As you ascend or descend, there's a pressure gradient. So supersaturation is basically as soon as you exceed a pressure gradient, you're going to start off-gassing. And this off-gassing is controlled by maintaining an ascent rate and doing stops at depth. So Haldane postulated a 2:1, which is basically assuming that nitrogen was the controlling gas, and based it on his observations on goats and himself and his family members. But later on, a workman who worked in the NEDU amended this to 1.58:1, which is the pressure gradient for nitrogen in the gas. And Robert Workman is the one who created the M values, or a theoretical constant, which is the maximum value any gas can off-gas before causing decompression sickness. So again, these are based on the hypothetical tissue models, and as well as the ascent rate, the number of compartments that you want to choose for that particular mathematical model. And decompression is still a theory. That's why we call it decompression theory. It's different for every human being as human physiology changes. It's different for dives. It's different for each depth. It's different for hydration levels. So you want to be really careful and make sure that you're following best practices when diving. Now, dive tables are something which you heard me talk about a little bit, and dive tables are a numerical representation of the mathematical model. So the first table, like I said, was in 1908 by Dr. Haldane, and the US Navy developed their own tables in 1915. Merrill and Spencer worked on bubble model tables in 1974. And in 2001, the Cochrane computer was created, which had a different algorithm from the normal ones. Most of these models were initially on animals, and then in the US Navy and the UK Navy started working on young military divers. So the average age was male. Sorry, average AL was 17 to 35, and gender was male. So when we dive today, it's a very diverse culture and very diverse number of divers whom we have. So the demographic needs to understand that any table that we use is not studied on the present demographic. So there has to be a certain amount of care being taken when you're diving, or you're dealing with a diver, to understand when they say I dived within the limits of my table, what were the limits of your table that you used, and what was your personal limits. And it's not the same for everybody. There are certain warnings, and there are certain omitted decompression procedures, which I would say in the most prudent way for diving is that you do not fly for at least 12 hours, and my advice is 24 hours after a dive. Again, the multiple things that impact diving and decompression, one of them is the dive profile as well. So altitude diving, multi-level diving, and multiple diving on the same day as well. So here's an example of a dive. If you notice the scale here on the extreme left is the inert gas, and this is on air. So nitrogen at 0.79 or 79%, and at 2 bar it is 1.58, and the ambient pressure on the right, on the bottom is towards the right, 1, 2, 3, 4, as we go from at surface level to 10 meters, 20 meters, and 30 meters. So think about it this way: as you descend to 30 meters, you're reaching 4 bar, and as you can see, there's a slight gradient increase in the percentage of nitrogen in your body. I am not showing you oxygen here because then it would create a multiple line, and oxygen is metabolized, so we kind of disregard oxygen to a certain level. Now you spend some time there, so the percentage of nitrogen or inert gas in your body increases. You start making your ascent. You're still going to be on gassing because there still is a pressure gradient in certain parts of certain tissues, and the faster tissues will start off gassing, the slower tissues will continue to on gas. So now this is assuming it's a mixed tissue. Now you've reached the place the line where you are off gassing, because now the pressure gradient is such that you're going to start off gassing. So you want to remain below the M value line, which is the red line on top. And this line, if you notice, and the M value line, if you notice, are both theoretically the slope of the curve. As long as you maintain the rate, you will stay below the M value line. And the M value is basically the slope of the curve. Now you made a straight ascent to the surface, and if you notice, this was the residual nitrogen pressure in your tissue. Now if you do the same thing and maintain a decompression stop, you'll notice here that as you on gassed, you're now ascending, and at your ascent profile, you've made a stop. Now when you make that stop, you start dropping gas again. And from that stop, you start ascending again, and your final your final nitrogen pressure is much lower than the previous example. Now we move to dive computers, and dive computers are a decompression device today. Instead of using a table, it is now a dynamic device which is utilizing depth, time, and in certain cases temperature, amount of gas breathed in, as well as the diver's heart rate to give you a custom decompression table on the fly. It will correct for changes in depth and changes in gas mix if you have the ability or the in the computer to change gases and adjust as you go. So now decompression sickness we come to the big what should I say topic of the big part of the topic, which you talk about: type 1, type 2, type 3, and type 4. Type 1 is generally not very critical and can generally goes away in a little bit. 24 hours is when you would look at resolution of most symptoms. Very rare cases, if there is significant pain, then the patient might need hyperbaric chamber treatment. Type 2 is a serious emergency, cardiovascular effects, neurological. You will also pulmonary barotraumas will also come under this type of decompression sickness. And then you have type 3, which is inner ear decompression, which is generally seen at depths below 150 meters, where you have a change in gas, and that gas gradient causes decompression in effects in the ear, which causes vertigo and can cause spatial disorientation. Type 4 is the long-term effect of breathing compressed gas and is generally seen in commercial divers and military divers, where you have a long-term degeneration of the long bones, the ends of the long bones, and which is why most commercial and military divers need to have long bone x-rays every 5 years, in some cases at shorter periods. Decompression sickness symptoms were too long for me to talk, so I just put this out here. I'm going to give you a second to look at it. So this is a table of fatalities and table of couple of tables which I've got further on now from the Divers Alert Network. They produce an annual report, and this is for the last previous years. The last one which I could get data from was 2019 and had a list of fatalities from 2017. It's critical to note here that most of the fatalities have been in breath hold divers and recreational divers, not in divers who are technical, military, or public safety divers. And that just goes to show that people who do more technical diving or more work-related diving have a lot of safeties in place and do a much better risk management than recreational diving. Again, this is a list of the years of diving which have happened, and you see it's more or less constant. It hasn't dropped at any particular time given the last, the 10 years of this. And the follow-up here indicates the fatalities on which they were able to do post-mortem and find out what caused the fatality. Again here, as you can see, males are predominant, and this is not because of the poor risk management by most males, but also because of the demographic of divers, where males generally between the age of 35 to 65 is the norm. So the first line for decompression sickness treatment is oxygen and pure oxygen and fluids. If you're on a dive boat and you do not have access to pure oxygen, then the highest, the richest mix of oxygen is preferred. Immediate physician evaluation and followed by hyperbaric chamber evacuation to hyperbaric chamber and follow-up treatment as required. If there is no physician available, call Dan, and the Dan hotlines are available on their website. If you're on a dive boat, they should have the hyperbaric chamber, the local hyperbaric chamber, and the Dan 24/7 number. Dan maintains a 24/7 hotline where there will be a dive medic or a physician available to give you consultation as to the nearest chamber and physician, dive physician. Now, one of the key things in follow-up is to check for a PFO or a patent foramen ovale. About 25% of humans have a PFO, and significant cases, number of cases of DCS have been in patients with an undiagnosed PFO. Now, it can be corrected and safe return to diving is possible. There have been quite a few cases and quite a few number of divers who have returned. They do have to maintain a slight degree of conservatism when they dive. These are my sources, and they are available. They're mostly, a lot of them are open source. However, there are some books and manuals which are available from various dive agencies. To summarize, we studied a brief history of hyperbarics. We studied the physics pertinent to diving with an emphasis on gas laws and understanding how gas laws affect on-gassing and off-gassing, basic physiology, primary respiratory physiology and cardiovascular system, barotraumas, decompression sickness and management, and a very brief overview of dive computers. Any questions? I'm going to stop sharing and we can move to questions. I'm going to mute myself and let questions come in as required.
There's one question from John. What are the current thoughts about children diving and growth plate injuries?
So the present consensus on diving is year 8 onwards for pool and year 10 onwards for open water diving. There is a depth limitation to 12 meters till they turn 15. The reason why this is for growth plate, and I'm also probably liability issues, but most agencies have a standard of 8 years in the pool, and generally pools are maximum about 2 meters. After the age 10, you can go into the open water and do and get certified, which is up to 12 meters. And after you turn, and you get a certification of a junior open water diver, and after you turn 15 is when you can, it's basically you can dive as till 18 to about 40 meters, and then from 18 onwards is decompression diving in deeper than 40. Does that answer the question, John?
Can you read in the messages another question from Lee, which is a long one,
right?
But I'll let you read it.
Which dive-related emergencies are more likely to have a delayed presentation? Ones we might encounter with patients that have already traveled back from a diving holiday and are no longer in a location typically associated with diving. There are some cases of, you'll primarily see barotraumas which were not detected at source. The patient might say they might have a fullness in the ear, which might come up as a inner ear barotrauma, which was not noticed, or even a mild barotrauma to the tympanic membrane. Also, the next question is about ocular findings. Is ophthalmic symptoms are generally seen with hyperoxia when you're breathing pure oxygen. So you'll find that in the rebreathers and military divers who've been diving pure oxygen for a long time, retinal detachment is a late finding. You'll have a lot, and also one other late finding is pulmonary issues when you have somebody who's done rebreather diving for a long time on hyperoxic mixtures. They tend to have reduced, I'm forgetting the medical term, but basically the pulmonary exchange starts, there's reduced surfactant and there's damage to the capillaries and alveolar damage. So it kind of resolves on its own in a few days, but that's what you'll find. So you'll find them finding difficulty breathing and mild cough. So they'll be trying to cough to eliminate eliminate carbon dioxide because there's improper gas exchange going on. Anybody else on clarity on those two questions, or is that good enough? I'd suggest anybody who has a question can just go straight live, and because we have a limited number of people here, can just instead of typing up, just hot mic yourself.
Got a couple questions.
Sorry, John, go ahead.
I got a couple questions for you. I think the word you're looking for earlier was a diffusion defect. Well, I'm a respiratory therapist and a bunch of other crazy titles. My question though for you is why are we still teaching spherical bubble phenomena in decompression when it's actually cylindrical? Because there's no part of your body that's spherical when you got it's a blood vessel is cylindrical. So when I compress it, I'm not really getting any big advantage of decompression. I don't think I said that very well.
Right. I don't see. I mean, I don't understand. It doesn't happen. It's just a theoretical demonstration. So when we talk about decompression, you're looking at the body as a holistic, as one tissue. So it could be, and there are multiple models. There is a diffusion slab model which talks about based on perfusion, you have different slabs. So the first slab gets the largest amount of on-gassing, and the last slab gets the least, and so on and so forth. So it's hypothetical, number one, and two, it's more of once the gas gets into the bloodstream, it's going to get off-gassed. So you want to keep the bubble size small. So as long as the bubble is small enough to get eliminated by a capillary, it's good. If it's big that it causes an occlusion of a vessel, you're going to have a problem. So we're trying to keep the bubble size small, and bubbles are going to be spherical. It's the compartment that's not spherical, which is right, which is what we do. When we teach it, we actually tell them that it's not a slab. It's a tissue compartment works differently from the slab model, which is just a model. Which is why we also tell people not to go by blindly on their computers or their tables.
The other issue I've seen though is when you're teaching decompression or recompression, I guess, is clotting. I'm going, you've got a foreign body basically, since it's air bubble in there. You get clotting on the end, and we wonder why people aren't getting better in decompression chambers. And it's actually a clotting issue, not necessarily an occlusion issue. Can you comment on that?
That is beyond my medical practice, but yes, that is the main issue. Is when you have an embolism, you're going to have a clotting, and there have been a lot of studies and studies still going on endothelial changes in tissue and changes in capillaries based on just even non-occlusive bubbles, because the bubbles are foreign bodies, and they will create a clotting cascade if uncontrolled. So there have been endothelial changes noticed, and reactive oxygen species changes noticed in human beings and in decompression theory and decompression practice. Sorry.
So Lindsay Ballard has a comment, and she's a hyperbaric doc in the OR. Lindsay, do you want to comment on this?
Sure. Yeah. So I did fellowship in Louisiana last year actually, and it's endothelial damage is what causes the dysfunction over time, and you could imagine even like in a heart attack or something, if it was a thrombus, it also causes endothelial damage, which can be longer lasting than just the transient passing of the bubble. So there is some benefit to the bubble, to actually squeezing the bubble down. And I know they're not always circular, like Vish was saying. Sometimes they can go along the longitudinal kind of aspect of the vessel, but the diffusion gradient is what improves the absorption of the bubble, no matter what, if it's spherical or if it's cylindrical over time. And that's why we use the 100% oxygen as opposed to any other gas mix in the hyperbaric chamber, to promote the diffusion capacity. But you can have lasting damage from the endothelial disruption. And that's why sometimes we'll do tailing treatments. So, there's like the official treatment that's like right after the incident. But often if they have any residual deficits, we'll continue doing treatments the next couple of days until we get a plateau or improvement.
And one of the things which Lindsay just spoke about was also, Dr. Lindsay said that you use pure oxygen, and there are also air breaks that you take in between if it's a long treatment, primarily to prevent the pulmonary effects of hyperbaric oxygen, of 100% oxygen. Correct me if I'm wrong, Dr. Lindsay.
No, that's definitely true. We do lots of air breaks, even in regular hyperbaric patients that are not there for emergency cases.
Thank you very much. Riley had a question about patient management. Do you prioritize getting the patient to the hyperbaric chamber or stroke imaging if you're concerned for emboli? I would consider taking the patient to the physician first and having them. I'm a paramedic, so I would, and a dive medic, so I would first take them to a physician to note, to get out of any differential diagnosis that I have. And it would be very clear if I have a diving incident and a patient has suffered from a deficit underwater, then I am going to consider it as a stroke because they're still underwater. And if they have stroke-like symptoms after coming back, which are getting worse, then I would consider it as emboli. And of course, as soon as they come back, I'm going to put them on oxygen. The first treatment would be high flow oxygen. If it starts resolving, then I know it's probably, it's most likely an emboli, a gas emboli rather than a stroke-related emboli. So there's a differential which one of the ways of getting a differential diagnosis for anything diving related is to put them on oxygen. If symptoms resolve immediately or near immediately, it's dive related, and they have to go to a chamber rather than anything else.
Tim, you had a question?
I did, yeah. Actually, we're talking about dive physics. I'm wondering if our dive tables that we've got them, are there any difference in terms of cave diving and open water diving? Or do we follow the same rules?
We follow the same algorithms, yes, but the difference is that in an overhead environment and wrecks, caves, mines, decompression diving, where you have a ceiling limited by decompression, you do not have access to the surface, which means that you have to do your decompression underwater, which means you cater for additional gas, you cater for safety, you cater for, so it's more risk, which is why you also probably notice the in the fatalities table, the number of fatalities in cave and recreational and technical and military divers was much lower, primarily because there is no surface. So therefore, like John commented, up is not the answer. So you stay and complete your decompression. Yes, there have been emergencies. I have known of one of my instructors had a diver who was attempting a 180-meter dive, and they went into cardiac arrest. They unfortunately did not survive. And he at that depth, anything beyond 50 meters, you start getting into decompression. So he had to bring the patient up whilst doing his decompression, and because that was the only way he could bring her up. So yeah, the main thing is changes in protocols rather than changes in and risk management rather than changes in actual dive table protocol, so to say.
And one more question, and I'm also wondering, are there any drugs that we would normally use in medicine that would be contraindicated in dive medicine, especially after somebody's been at depth? So I'm thinking of, when we talk about dive medicine, we talk an awful lot about pulmonary embolus and we talk about decompression illness and the like. But, divers, in my experience, on the commercial side anyway, they suffer trauma type injuries too. So the likes of TXA, would that be contraindicated, or could we use that in a traumatic amputation, say? I mean, I've had guys certainly trap the fingers, hands, and the like.
So I haven't dealt with anything like that yet, post diving or in a diving related incident. But given, I would defer to the risk versus benefit answer. If you have a traumatic amputation, once you've lost so much blood, what are you going to do? If you have the patient in a wilderness medicine setting, you'd probably put a tourniquet and get them to a chamber and to definite care as soon as possible. That would be your evacuation is your only safe bet. For anything diving related, and I've had a colleague of mine who had a rapid ascent from 55 meters to the surface in less than 5 seconds. He had a malfunction on his suit. He suffered severe decompression symptoms immediately. He got onto the surface. He was unconscious. He had bleeding from his ears and nose. He was taken straight into the chamber right there. It was a commercial diving incident, so he was within 2 minutes he was in the chamber. So prognosis was good. He was able to. It took him about 6 months to a year to get back, but yeah, to give you an answer, it would be more of risk versus benefit on medications.
Okay, thanks, Fish.
I mean, diving and medicine for me is mostly pre-hospital in both cases. So I haven't gone into long-term effects of medications post any. Dr. Ballard, any comments on that?
Sure. To the best of my knowledge, there's nothing that you can't give after the dive. There are plenty of things that you would not want to give or utilize before a dive. But I also work in the emergency department, and there's nothing that I've really come across where I've said I really don't think we could use this if we really needed to in the situation.
Thank you.
Thank you.
Are there any book resources that you can recommend for further reading? I would say Bowen Davis is my favorite, but there's hyperbaric medicine. There's a lot of books on hyperbaric medicine, textbooks, and I would say it doesn't matter what level of clinician you are. The more you read, the better for you and the better outcome for your patients. There'll be some obscure text that you might read in a book or in a paper that is way out of your scope of practice, but it might just come handy when you on that one day when you need it. So I would say just read as much as you can.
Got a question for the group if I could. This is an international group. Military and commercial, they're pretty regulated. They have pretty good standards in terms of what you're going to see if there's an incident. My concern has always been with the recreational or the leisure, quote, industry diving out there. What do you guys see across the world? Is there a standard? Should there be a standard? Or are we just taking my chances if I go down to the Caribbean and want to dive for a couple of days, depending upon the quality of the captain and the company?
So I'm going to say, in my experience, a while back now, I did the whole PADI instructor. I realized that I wasn't going to make much of a living out of it. Lifestyle's great, but I wasn't going to make a huge amount of money. But I remember several emergencies. I did an assisted ascent with a student who who basically showed signs of narcosis. We were doing a deep dive profile. I think the bottom was around 45 meters, something like that. Either way, that the student wasn't very well, and I took the student up to the surface. But I certainly know for the organisation I was with, you know, we had oxygen on board. I'm actually a DMT. I did my commercial dive medic stuff. I did diving in the military as well. So all in all, as far as I can see in my experience, you've got some good dive masters out there. PADI does its rescue diver. All dive masters need to have some form of basic kind of medical qualification. So in my experience, most seem to have been very well prepared. I think the only thing that you never really have readily available to you in a recreational setting is a dive chamber. So you're relying on whether or not, depending on where you are, the proximity of a dive center, and obviously search and rescue if they can get you there on time. So I think it's more about location as opposed to the any company in itself. There are definitely standards, BSAC, British Society of Aqualung, something or other, certainly PADI, International Divers Inc. I know there are various organizations out there, and having been through the BSAC and the PADI process, I would say the standards overall are pretty good, as well as the training. But life isn't perfect, and not everybody follows those rules.
Just to add on to what Tim said, I run a dive shop myself. I have a dive school back home in India. I teach recreational and technical diving. I would say anybody going to dive, it's a leisure sport. You're investing a lot of time and money in learning to use life support equipment. If you are going to a place to do a recreational or a technical dive, basically you're diving for fun, you should do your own due diligence in terms of risk management, calling up the dive center, sending emails, exchanging. And it's very clear in my mind that the minute you get no response from a dive center to any safety question, it's somebody whom you don't want to go diving with. They might be busy, but if they are answering questions on how much it's going to cost and whether you can book in now, or whether they have a page on their website that says, click here and book now, they should have somebody to answer the phone or answer an email that says, this is what our safety procedures are, this is what our safety protocol is. Once you're on the boat, everybody should do a briefing as to where the oxygen is, where the nearest chamber or physician is, what are the capabilities of the boat and how fast and how far it is, and anything else. There should be a briefing right there and then before you start the dive. And if you don't feel comfortable, don't dive. It's your life, it's your well-being. I have not had the opportunity yet to call a dive because I was feeling unsafe. Primarily because I did my due diligence before going, and I have dived pretty much quite a bit across the US and some parts of Asia as well. So I would say it's like Tim said, it's relatively safe, but if you ask a question and you don't get an answer, that's a red flag.
George, you had a question about paramedics. I put a link on to international standard for paramedics and docs to get certification to start working as a professional dive medical technician. And there's other courses in there, is the LST, life support technician, and the ALT. So there's jobs available for us paramedics.
Yeah, I think for as far as I know, for paramedics or EMTs and even EMRs, you need to have at least a rudimentary DMT or a chamber operator, which is a CHT in the US, to be working as a dive physician or a DMT, or at least a DMR, some understanding of some level of training in understanding how chambers work and what the physician basically needs you to do in case of an emergency or a pre-hospital situation.
So we're a little past our hour. I wanted to open this up for administration questions as well. Anyone have any questions for the college or how this student interest group works and how you're going to get credit for your FOM? Fair enough. Easy enough. It's all on the WMS website. But at the end of these 12 sessions, we'll give you a cert for the sessions that you attended, and then you can use that for applying to your fellowship. But we will be doing this the first Tuesday of every month, and we look forward to seeing you guys again in early October.
I'd like to thank Dr. Lindsay and Tim for their valuable inputs on the questions. And thank you, Ebrick, for moderating this today.
Have a good evening. We'll see you guys in a month.
Thanks very much, Vish. Thanks, guys.
Thank you very much. Nice to see you.
Nice to see you. Yeah.
Hello. Bye.
This was definitely a pleasure and enjoyment. I'll look forward to the next one.
Thanks, John. We're trying. This is new for us, so we're.
Can you hang around a minute or two?
John.
I got
No
hundreds
problem.
of questions for you. I can't type all these questions.
Let me turn off the recording so I can't get in trouble.
Yeah, it's okay. That's very few time I'll